Hi and welcome to the STAR presentation. The STAR team is known for its social therapies assessment and rehabilitation team, and we are based on AMU, ED and Cavell. During this presentation, we'll just talk through a little bit about what our service is, what we do and how you can refer. So who we are an MDT of therapists, of which we have physiotherapists, occupational therapists, and therapy technicians. We've got a range of experience within the team. We have 1 Band 8, 4 Band 7s, 4 Band 6s, 2 Band 5s, as well as 3 Band 3s. So there's a good breadth of experience within the team. And do not hesitate to contact any of the seniors if you need a senior approach on anything in regards to a specific patient. As mentioned, we cover the ED department as first base. We also then cover AMU and AAA, and then also Cavell ward, of which patients are aiming to be an extension of AMU and have a short stay of up to 5 days, ideally. Our team, it works 7 days a week, so we do cover over the weekends, but we are on a reduced service. So on the weekend, we'd only have 2 therapists essentially covering STAR, so we're still trying to cover those areas. So do appreciate on the weekend we might have a bit of a reduced service, but we do prioritise ED and AMU on those days. We cover across obviously the whole year, including the bank holidays, and our service runs from 8:30 till 6 o'clock. And the latest referral that we can accept is 5 o'clock, just in regards to then taking out the assessment and doing any onward referrals that would be required. This is more applicable to those patients in ED, but just so you are aware. And the aim of our service, the aim of our service is supporting the team in admission avoidance where possible, and whereby that's safe for the patient and maybe in their best interest actually return home. So like that, we're optimising a safe pathway, so often referring into community therapists, district nurses, and with social services in regards to package of care. And also we can help in signposting family or carers with multiple adjuncts such as ball sensors or some of the charity services that are available should they be already at their maximum package of care or needing a bit more general support. We can help with signposting in regards to that. But like I say, do ask us if you have any questions in regards to that, because it can vary from borough to borough. So who can you refer, which is probably the key information for you guys starting work over in AMU. So we will see anyone, there's no age limit as such within our team, unlike within the OPAL team who generally see people over the age of 65. So it can be those elderly patients who are particularly off their functional baseline, and that being like the key point. So as you can see, there's a range of presentations that could present that would then lead to them being off their functional baseline. So any of the above or any others that may affect their function, then those ones can refer to us. Equally, those younger patients who are off their baseline, quite often those that have long-term health conditions or neurological conditions, we often will see those as well. And we are responsible as per like NICE guidelines in doing a basic neuro, especially with those that have been triaged or has a diagnosis of a stroke. So we will see from a physio and an OT perspective. So those parties will do their own professional assessment. We also get multiple patients that present with back pain. We will see those that are immobile. So often it's if they're presenting in this area, it's pain that's often the issue. So ideally, we will get involved once their pain's been optimised, because otherwise it's very difficult to sort of build any kind of trust with that patient in getting them to engage in mobilising. For the vestibular patients, we can assist, but equally I think you guys often will do some of the manoeuvres as well. Spinal fractures, we are able to support once it's been cleared from the neurosurge team or ortho team as to their restrictions, or if it's being conservatively managed, we can help with braces and collars. And head injuries, so we do have occupational therapists who have specialist training within cognitive screens. So that's something else that we will make sure we do, including like the PTA as they go onto the wards. And what we do, I mean, it is quite extensive. There is a bit of the general rule is that we're looking at patients' function and trying to optimize their mobility and general function so that we can get them home. But as you can see, and as discussed with the patient cohort that we see, this isn't just what we can do. We have quite like a breadth of different things that we can offer to the team. But the key things really are enabling safe discharge plans for patients for leaving hospital. We will set up, or essentially, we will set a referral for the team, which will go to social services with the recommendation based on what we assess. That is limited by what the timeframes are with social services, and they can action that. So sometimes, if we've said that we've sent the package of care, the delay essentially won't be from then our side. It would be waiting on what social services have the capacity for. And then the other services, just to make you guys aware, so we often can send patients home with urgent therapy follow-up, but also we have the options across different boroughs, which include Queen Mary's for those that are in Wandsworth and Lambeth, and Ronald Gibson House, which is predominantly Wandsworth patients. And then we have Heathlands, which is for those that are in Merton. And these bed-based units are an opportunity to get people that are significantly off their baseline back to, with some rehab, to get them back to a sufficient level that they could manage at home, and then quite often will need further therapy at home. But if they're significantly off baseline, this is often somewhere that we would look to send them before sending them home. And how to contact us and refer. So our main bleep is 6622. Okay, so feel free to speak to us if you have any questions in regards to referral that you may feel may be appropriate. But like I say, that's how we can be contacted throughout our hours. And also, we can get referrals directly at ward rounds. Often these come from the consultants, but if you're there present and you know that the patient's going to need us, then feel free to raise it. Please make sure that you ideally have referenced it at one of the ward rounds and bleeped versus just being in the notes. We do screen through the notes of each patient that we feel may be applicable. However, just to make sure that nothing gets missed or they get prioritised at a lower basis based on what has been documented in the clerking. Sometimes, obviously, plans change and it might be that you feel this patient could go home. But from what we read, it may have deemed that they are going to take 48 hours. And obviously, if that's changed and the notes aren't updated, then we won't know. So do let us know, and then we can hopefully see them quicker for you. And what can you do to help? Like I just said, referring early with as much detail as possible really helps because we can get things moving a lot quicker. The earlier we know about it, the earlier we can send referrals to social services and hopefully reduce the delays. Currently, there's been significant delays in both packages of care and awaiting bed-based rehab. So that has limited a significant amount of patients in leaving the hospital. But I say, as soon as we can get the referral in, the better. In regards to patient sort of priority list with ourselves, obviously there's 58 patients in AMU, A&E and Cavell. We have a prioritisation system, and the P1 as such is those that are aiming home that day. So they will be the ones that we would see first, and those that are still medically not optimised, they would be classified as a P2. We will get started where we can, but it might be that they might not be seen until the next day, depending on the caseload. If you are speaking to any family members or next of kin who happen to call in, if you can always get an updated telephone number, because quite often sometimes the numbers don't match with that of EPR, that can really help us, because I think often family members try and contact the ward or doctors on a different number to what we often will have documented. So if you do speak, if you can just jot it down, that will really help us as well. And with that, if you find out that the family are raising concerns with cognition and function, even if you write that family are concerned with these points, that aids us with making sure that we thoroughly assess both of those areas, or which one is in question. And if you require chest physio across AMU, then our colleagues in the respiratory team have chest physios that will cover AMU, and their bleep is 6575.